My name is Dr. Edward Ngwenya, and in this podcast, we'll be speaking about penoscrotal defects as we continue in our series of the genitalia. So let's speak about penoscrotal defects. Remember, as I always mention, we've covered in this, in case you've missed, the embryology of the genitalia. We've covered the vulvovaginal defects. We've also spoken a lot about transgender surgery. So if you can revise those, perineal recon, we've already discussed. And today we'll just spend some time on the penoscrotal defects, as one has received much questions regarding these. Again, I go back to what I always mention. This does not seek to replace your learning, but only to augment it. And I strongly encourage you to always go back to your books and just check and conceptualize a few concepts, as I always try to go on a high level. I say high level, and then we end up finding ourselves going a bit deeper into details. But let's go in the basics. Anatomy. You know the anatomy, you'll be able to understand the surgery and what we go through. Speaking about the penis, if you divide the penis, we basically speak about the penis being composed of, the root, which is proximal. Remember, we speaking at anatomically. So the proximal part is the root, and then we've got the body in its central portion, and the glands, which is distal, and then we've got two surfaces: the dorsal surface of the penis, which is continuous with the anterior abdominal wall, and it's therefore only dorsal when the penis is rather erect. The root, let's go into those three parts. The first being the root, which is attached to the inferior surface of the perineal membrane. And so this will consist of two things, or rather three things: the bulb of the penis, which is centrally based. So you will see that this continues as the corpus spongiosum in the body of the penis. So the bulb of the penis, and this is penetrated by the spongy urethra and paired bulbourethral arteries as they travel down. Then we've got the crura of the penis on each side of the bulb. And each crura continues as the corpus cavernosum. So we've got the corpus spongiosum in the middle as a continuation of the bulb, with the spongy urethra in there and the paired bulbourethral arteries. And then next to it, we have then the crura, which is the corpus cavernosum, which continues in the body of the penis. And these are attached to the ischiopubic rama, the crura that is. And what you will find is the deep arteries of the penis will then enter each crus to run in the corpora cavernosum. And then we've got now the muscles, which are your bulbospongiosus and your ischiocavernosus muscles. We've by default spoken about the body when we've spoken about these central structures, the urethra, and they're covered by the corpus spongiosum, and then the corpus cavernosum on each sides, with the deep arteries they're penetrating therein. And so the body will then consist of two adjacent corpora, as we've mentioned, cavernosum on the dorsal surface, but a single spongiosum on the ventral surface, containing the spongy urethra. So now, as you can imagine, you've got these three cylinders of tissue, and so they've got to be enclosed by something. And so what enclosed them immediately is the tunica albuginea. So the tunica albuginea will then cover this, and then superficial to the tunica albuginea will then be the deep fascia of the penis, and that we call or we know as the Bach's fascia. And this will cover also all three corpora. So the three cylinders are each enclosed by the tunica albuginea, and then and this circles each of them individually, and then the entire then thing will be enclosed by the deep fascia, which is the Bach's fascia, that then encloses everything. And the Bach's fascia, what you should know about it is that it's continuous with the deep muscle fascia at the root. And you see the paired dorsal arches of the penis, which are dorsal vein, the arteries, and the dorsal nerves, will then be continuous where within the Bach's fascia, and there you will see they lie dorsally, or rather, yes, dorsally then in, and below then would be the bulbo, or the corpus spongiosum with the urethra ventrally. Now, we've got this enclosed by Bach's fascia. What then is going to follow? Now, superficial to the Bach's fascia is skin and subcutaneous connective tissue. Now, this is a part I need you to know. Now, over the penis and the scrotum, the subcutaneous connective tissue contains abundant smooth muscle fascia, and this is then called Dartos fascia. Over the penis and the scrotum, subcut tissue, it contains these smooth muscle fibers and is called Dartos fascia. Now, Dartos fascia is that which is continuous with the Colles fascia of the perineum. Very important to know, especially when we start speaking about necrotizing fasciitis or Fornius gangrene, and the potential spaces and how it can then spread. Now, we've got the glands right distally, which is the distalmost part of the corpus spongiosum, and it expands to form this conical shaped glans penis. Glans just means acorn, so it's a Latin word, and as you can imagine, you've got this proximal prominent margin of the glands, thereafter called the corona, and then after you would then have your body. And then we've got the urethra. We know about the urethra. There are three parts in a male urethra, and this would be the going all the way back, the prostatic urethra, and that's within the prostate gland. And then we have the membranous urethra, the part that goes through the deep perineal pouch and pierces the perineal membrane to become the penile urethra, the shortest part therein. And so the penile urethra, which is also known as the spongy urethra, as it lies in the corpus spongiosum, then continues opening up into the meatus. I think that's the important part. What else can we speak about? I guess the dorsal nerves of the penis, and generally, where would you find them? They extend from 11 and 1 o'clock to about 7 and 5 o'clock positions on the corpora cavernosum. So those are the general positions of the penis. So whenever you're going to do any plication or cordy, so you're looking at aiming anything at the 12 o'clock position, because that's where then at least you will then miss these vessels. And also in this area, the tunica albuginea, just remember, is the strongest. And potential nerve injuries, which could actually affect, later sexual function, can actually be avoided if we go in that 12 o'clock position. I think that's enough. Basically, the penile artery, the common penile artery, I think we know about it. It's a branch of the internal pudendal artery, and it branches to then give off the bulbourethral artery, the dorsal artery, and the cavernosal artery. And these would then supply the areas respectively. I think when speaking about the male, it would be incomplete if we don't speak about the scrotum. And perhaps it's important just to know the layers of the scrotum. From outside, we've got our skin, then we've got the dartos fascia and muscles. Remember, as we've explained, then we've got the external spermatic fascia, then we've got the cremasteric fascia, the internal spermatic fascia, the tunica vaginalis, and the tunica albuginea. Those are just the steps. I think that's enough. I'm not going to speak so much into this anymore. I'm trying to decide if we should discuss hypospadias here or we should have its own separate talk, because hypospadias is actually a huge topic that I think would require its own time. But perhaps I should not get into detail, but just to give a synoptic overview, excuse me, we can just merely define it and say hypospadias. What is it? It's just an abnormal opening of the penis, or of the urethra rather. And so you need to be able to then give the three characteristic, descriptions of the deformity. And this is a triad, as I've said, the three. What are they? Number one, there's an abnormally proximal urethral meatus positioned on the ventral aspect of the penis. And this speaks to the embryology. Generally, we know that the urethral folds coalesce in the midline, and they go from the base all the way to the tip, forming this tuberalized, penile urethra and the median scrotal raphe. Now, this will then account for what? The posterior and middle urethra. Because if this doesn't happen, then you're going to have that problem. But also, there's the anterior or the glandular urethra, and this depends on what you believe in. And there are two theories: the ectodermal theory and the endodermal theory. The ectodermal saying, look, this all happens from proximally going all the way down distally, and then on the glands you've got now ectoderm that penetrates from there to meet the urethra in the middle. And so if this doesn't happen, then you are going to have meatal openings in the corona, or the upper third, or rather the anterior portion of the penis, which is the glans. And so, of course, it speaks to the higher incidence of the subcoronal hypospadias, which then may support, that vulnerable final step. And these will give, the ventrally deflected, urine. Urethra. And so you will find out on history that when they urinate, the urine stream splays, rather than going on its straight line. So abnormally proximal urethral meatus is the big one. And number two is the hooded prepuce. And what forms this hooded prepuce? Generally, it's thought to result from, a growth disparity. Remember, I've mentioned the embryology. So there's this growth disparity between the normal dorsal tissue of the corporal bodies and the reduced or attenuated ventral urethra, and associated tissues. And these would cause this problem. And so if someone had a hooded prepuce, they will have a painful erection, ineffective copulation, inadequate insemination because of this hood that then forms. And then lastly, we have a chordee that forms. And this is the abnormal curvature ventrally that forms. And it speaks to a couple of things: a failure of fusion of the urethral folds and the dorsal hooded prepuce, which can give you that tight frenulum and chordee. But generally, we have the abortive spongiosal tissue and fascia that's distal to the urethral meatus, and what that does, it forms a tethering fibrous band that contributes to this chordee. So this will give you, adverse effects on psychosexual development, but also the painful erection would then come from that. Three things: abnormal proximal urethra, hooded prepuce, and the chordee. Note, whenever you see these kids, you always look for the associated anomalies, which are the most common: the inguinal hernia and undescended testes, cryptorchidism, as we call it. And also, just don't forget that they may have upper renal tract abnormalities, especially, in penoscrotal and perineal forms. And so you'd look for all of those: your vesical urethral reflux, renal cysts, whether congenital urethral fistulas. And so for these, you do a renal sonar, and VCUG would be recommended. Disorders of sexual differentiation, very important. Suspect them, especially when you see a micropenis, penoscrotal transposition, or a bifid scrotum. Remember, in this, what's important for you to know, and I'm not really gonna touch on this, but perhaps all I will say is just know about your classification of disorders of sexual differentiation. We group them in three. One, it can be chromosomal based, or the cause is chromosomal. We think of our Turner syndrome, Klinefelter's, which will fall there. I think 47 XXY. Turner would be, I think, 45 X. And so those are the things. And then the other then will be other two groups. The one would be the 40, is it 46? Yes, 46XY, and the other 46XX. The 46XY, we further differentiate them into issues with gonadal development or issues with the androgens. And the other, same story: gonadal development or problems hormonally. So, and then of course there's many others that you can add there in, but that's DSD. So just make sure you exclude that. And just extra urogenital issues, cleft palate, always add it in, malformations or anything, congenital heart disease, musculoskeletal anomalies, and erectile malformation, but these are often rare. And so I think, I'm not going to go into the embryology. We've spoken about the classic endodermal ingrowth theory and the recent endodermal ingrowth theory that we, kind of hold. But something quite common: 1 per 250 live births, and it's associated with a lot of things: a defect in androgen stimulation. There's a endocrine cause, perhaps, where we think the human chorionic gonadotropin is diminished in response, or you get a diminished response to that, and so you get delayed maturation of the hypothalamic and pituitary axis. So those are the things that you'd look at. There's environmental causes, or rather associations, as we've seen. Some studies showing winter conception as a problem, and then genetic. But certainly, I would say the way you want to deal with them is to then look around, for other anomaly and make sure you get a handle of those. Now, how do we manage these patients? You choose different units. Others, it's the urologists who deal with them. Others, it's pediatric surgeons. Others, it's the plastic surgeons. But you need a good team. But the principles is what I'm going to speak to, because if you look at it with Scrooge, there's a lot that has gone on and a lot that has changed, especially when it comes to the urethral plate. And we tend to hold a lot of different views, plastic surgeons, urologists, etc. So just make sure you're up to date to understanding this, because it's something that it causes a big problem, but something that the recurrence rate and the breakdown is very high. And so you must be quite meticulous in this operation. And the way we manage is surgical repair. Some would say, look, if you've got a CORDI classified quite low, you need not come and repair it immediately. But you would then repair all others. And what are all others? Remember, you classify them either as anterior, middle, or posterior. Anterior, which are the most common, 65 to 70% of the cases, it's either glandular, coronal, or distal, penile shaft. And then you have the middle ones, with your penile shaft, hypospadias, and then the posterior, which are the second most common, 20% of the cases. And that would be your proximal penile shaft, your penoscrotal, your scrotal, and then the perineal ones, which fall then in. Now, what are the ways that we'll manage? I think let's speak about the timing. Ideal timing. When do we want it? At 6 months. 6 months, I think you won't go wrong. Look, there are different schools of thoughts. Others say no, wait till about the first 3, maybe later on 4 years. But we've seen that waiting makes little difference to the size, because the penis grows less than a centimeter during the first 3 to 4 years. Others say, no, maybe if we're going to do it early, then let's give some preoperative testosterone, DHT, beta-chorionic gonadotropins. Look, it may be useful for those with small penis or for repeated surgery, but the main thing, and that's one I always argue, is that it doesn't change the position of the urethra. So really, I think we generally in our setting don't use it. So ideal timing, we use 6 months. Anesthetic risk is lower. Post-operative care is easier with a toddler. Than in a toddler, and you've got minimal psychological impact. A good history is good, the examination is good, and then we go on to theater. Now, what are our goals or our priorities? And we group them in 5. I think that's the main thing. The goals of repair, the first is orthoplasty, which is complete straightening of the penis. What does that entail? It's releasing the CORDI. That's what it is. And then 2, we look at the urethra. It's urethroplasty. We want to construct a neo-urethra that's uniform in caliber. Number 3, then we look at the meatus, the meatoplasty, where we want to locate the meatus at the tip of the glans. Number 4, then we can go to the glandsplasty, where we'll then form the symmetric conical shaped glands, and the last being skin coverage and more the aesthetic part, which is completing, a satisfactory cosmetic skin coverage is the main thing then in those. And so maybe let me just touch on a few technical elements. When you start off with the operation, you will do a Horton test. Others give it many other names, and then measure the level of the CORDI. So what is a Horton test? You just make an artificial erection, and then you assess the degree of the CORDI. So you inject normal saline into one of the corpora cavernosa after applying a tourniquet around the base of the penis. We used to speak of, many different things, and things are changing generally in terms of block. Others would then say, no, let's use a caudal block. Others say, no, a penile block has found to be greater satisfactory results. And these things keep flipping. I mean, through one's training, I've seen the caudal block was once hailed as high, and then it seems the penile block is coming on now as the better one. You need good lighting, you need good instruments to be able to carry out this procedure. You need, loops if you you use them, and generally the type of sutures that you will then use would be important in managing these patients. And generally we use a 6 or 7 absorbable suture for the urethra. So a fine chromic for the skin works excellently. And then just remember, you want a urinary diversion for 1 week after that, and you want a silicone dressing over your repair. We prefer a transparent adhesive dressing on the penis so you are able to look at your repair, and also putting the patient on post-op analgesia. But what we use is Detropan, which is an anticholinergic drug. And what do we use there? Just to prevent the spasm of the penis, and also, limiting that erection, which may be a problem therein. So I think those are the main points that you must know. And then how you fix it, this varies a lot. I would just say it's best to know the options that you have. And what are the options? You can have a meatal advancement and glandsplasty, which is a MAGPI, and that's if you have a very stenotic meatus with good mobility of the urethra, and a fairly shallow ventral groove, or granular ventral groove. And so this will assist you, and it's almost like what we do when we do or what the pediatrics would do when they do a pyloric stenosis. And what you want is just to make a longitudinal incision, diamond shape you can use, and then you just close it transversely. You just do a transverse closure, and what it does, it advances and it extends the size. So that's very simple to do for a urethra that's right there, at the tip, and you just need to advance. But then for mega urethra and other things, then there are other procedures that have been mentioned. But a procedure that I would advocate that you should know and know well, as it's the one that will get you out of a lot of trouble, is the tip, the tubularized incised plate urethroplasty. Excellent option. You incise the urethral plate longitudinally, and then you do your glans incisions longitudinally, just wide enough to leave at least 2 strips of epithelia for the 10 French size neourethra. And then you perform now your neourethra that you tubularize in the midline with multiple layers. You include dartos flaps for reinforcement, and then the glans wings you will close also in the midline, and then you do a skin closure. So that has shown to work a lot, especially in your proximal, your middle, and some even push it as far as the distal. And that's certainly something. Now, I'm not going to get into the urethral plate, and there's a whole lot of talk. Initially, people saying, no, you don't want to incise. And now talks coming in saying, no, you got to incise that urethral plate. In fact, that's what's going to give you the lengthening, blah, blah, blah. So you read about the controversies, but just have an understanding on the principles and that which you are trying to do. There are other flaps, the onlay island flap repair, the two-stage, the Hand-Smith repair, the transverse, prepubesal island flap tube repair, but all of these just trying to do the same thing, but just mainly using prepubesal skin to then form the tube either partially as the onlay or wholly as the transverse island flap tube repair. There are complications. You best know. Early complications, intraoperatively, you're going to get bleeding. You may have necrosis from the prolonged tourniquet. So just watch. You want it to be there for 20 minutes max. And then postoperatively, your bladder spasms, so hence we give our anticholinergic, hematoma, wound dehiscence, edema, flap, necrosis, and an erection that can really cause complications. But the late complications, that we get fistula, most common complication of hypospadias repair. Urethral stenosis, proximal stenosis usually common, diverticular may form, sexual dysfunction, retrusion of the urethra, or just persistent, UTIs that these patients may get. And that's, hypospadias, quite complex, and you will get some patients who keep coming over and over and over and over, and those who have even been given a term known as the hypospadias cripple. The I think it was Van der Werf and Van der Meulen who defined this hypospadias cripple as a patient with persistent functional complication after previous hypospadias surgery. And so there are different techniques. You can read about them. Snodgrass, very big in this, who suggest that maybe using urethral plates for reoperating these hypospadias in selected cases. But there's also the two-stage Bracker's method for repairing that you can go in and have a look at it. But I'm not going to get into those details now. So that is hypospadias. I think we've taken care of hypospadias. I didn't mean to get into so much detail, but it seems we covered it, and all I wanted was just an overview of it. But it's fine. So now, what else do I want you to know? There's epispadias. It's the urethral opening on the dorsal aspect. And I mean that's something that can happen, especially proximal to the bladder, neck. This can lead to incontinence. And so there are different techniques. I'm not going to go into them. The Young technique, the W flap techniques, your Catwell, Rensley techniques that you then use, using circumcision incisions to perform this shaft declaving of the shaft base and basically tubularizing the urethral plate. And so those are the different techniques that can then be used. Now, there are other anomalies that you must know: the bladder extrophy epispadias complex, which I'm not going to get into. Idiopathic scrotal edema, something that is generally there, uncommon, but can occur in boys usually 3 to 9 years of age, affecting the scrotum and adjacent structures. So you just need to know about this and how we treat them. But acute swelling generally subsides, but in some cases you may have skin discoloration that persists for a longer period, and antihistamines may be given for these patients. Now, of course, scrotal swelling, you want to exclude big things, torsions, hernias, etc. Now, what are some of the acquired defects that we can get? Peyronie's disease is one of them. I'm not going to get into Peyronie's disease, but there are different ways that we can use. And one of the ways, actually, fat grafting has picked up a lot. Fournier's gangrene, generally an infection that's there. I'm also not going to get too into it, but it can really spread, from a urethral obstruction. And so you get this leaking into the different fascia. They pass on to the Barks fascia, spread along Dartos fascia on the scrotum, and then Colles fascia and Scarpa's fascia of the perineum and abdominal wall, and this can be quite fatal. I think let's get into penile reconstruction maybe. There are different reasons one may want a penile recon. It can be partial, it can be total. I'm not going to speak too much about partial, but total recon. Also, I'm not going to go too much into detail, but mainly the reasons are either traumatic or there's gender reassignment where the female patient wants to become a male, so the female male sex change, or there may be cancers, a squamous cell carcinoma, perhaps of the penis, and so then you'll endeavor in this total recon. But we our goals are that we want a one stage, reproducible operation. We want predictable results. We want to create a competent neo-urethra that will allow voiding when someone is standing. We want to restore a cosmetically acceptable, penis with tactile, and let's say, we need that erogenous sensibility. But also you want it to have enough bulk to allow insertion of prosthesis if and when necessary. And what options do we have? The reconstructive techniques are vast. We've got the gold standard, which stands out now, is free flaps. Your free radial forearm flap is the main one. There's different methods: the Chinese, the modification by Gottlieb and Levine, the cricket bat technique, and many other techniques that we use, and I'll explain to you my technique of choice. And then we've got alternative techniques where we can use any free sensate osteocutaneous fibular flap. You can bring that up, and if you want, it's been described that this can be pre-laminated with a tubed skin graft to form a neo-urethra. There's a free scapular flaps, there's infra-umbilical flaps, there's pedicled ALTs described by Lee, in the colleagues. But those are usually the things. And for urethral reconstruction, you may then use your skin grafts, which are taken from the inner thigh. You may use the abdomen, you may use the scrotum, you may use grafts of saphenous vein. I've seen articles describing appendix, the ileum, the bladder, as other sites that may be used. And for surface defects, I would just stick to a skin graft. Skin coverage is the best option, whether it's a split thickness skin graft. Generally we know that's a bit, cosmetically it's inferior. Compared with your what do you call this, your split thickness skin graft. So for these patients, we rather prefer, as I've mentioned, a non-meshed skin graft rather than taking one and meshing it. And we know the contractures. It may be hard to keep it around there, so foam dressing, negative pressure wound therapy can assist as an adjunct to help in terms of healing. But when we convert from male to females, we can then use, other skin and mobilize that to assist us with the recon therein. So what are the procedures? There's the one-stage penile recon by Chang, early in 1983, described it. There's the modification that was made by Gottlieb and Levine in 2017, where the way it was raised, instead the urethral portion is in the middle. And then there's the cricket bat, which is your transformer phalloplasty by Gilbert, who described that. But generally, what you want in any technique that you are going to use, You just want to create a tube within a tube. And I would encourage you to have a look at some drawings. I enjoy actually using this one that's described in Grab and Smith. If you look at the chapter on penile reconstruction, it's actually quite well described there, and the drawing is actually quite good. I think it's chapter 99. Just have a look, and it's well described. I think that chapter was written by Joris Haig, and quite great. J.J. Haig, beautiful. Description therein. From female to male, there's the meatidio, your met adoi plasty, where you lengthen your clitoris, basically lengthen the urethra, use the flaps therein, but it gives you a small it gives you the sensation, but it gives you a small penis, actually not quite compatible with sexual activity. But the modification of the graph one that's modified, it's quite good, because there you can now have triangles in front that can actually match the flap, the corona, the glands, creating that conical shape. So you create a urethra. Just technical points to mention is the part that you will use for the urethra, preferably use the ulnar side. Why? There's less hair that grows there, so that's why you use that. And of course, in all of them, you'll have that 1 centimeter bridge that will allow you to fold the urethra on its own, and then fold it within, or fold the other portion of the flap around to create the penile shaft and the gland that accompanies that. And that generally should give you a good result in operating. Of course, when we speak about the male, we must speak about scrotal reconstruction. And generally, without spending too much time there, the techniques that are used for the scrotum to cover, you use your skin graft, whether split or full thickness. You can use superior medial thigh flaps, pedicled ALT, gracilis flap with skin graft, or tissue expansion of the perineal skin, or actually remaining scrotal tissue, and then using that. I like to use, your thigh flaps, the superior medial thigh flaps. They work very well to use them, and you can generally, as you would when the scrotum is out or exposed, you bury them within the thigh, and you can actually raise them with a portion of the skin therein. And they've got generally good supply. There are muscle flaps, as Elaban described in 2003, where you would use your gracilis or rectus abdominis flaps to then assist you with that. But I think your superior medial thigh flaps generally will help you to be able to cover your scrotum. And I think that should be it. With that, I think we've covered more than we anticipated, and you should have a firm grasp on penoscrotal defect management. I look forward to the next talk. Goodbye. Goodbye.